Okay, so today I'm going to be talking about our study about the relative risk of copper and hormonal IUD users, which was published recently in Obstetrics and Gynecology, also known as the Green Journal. So to provide some background, intrauterine devices, or IUDs, are used as a form of long-acting reversible contraception by about 100 million women worldwide. The two main types are copper and hormonal. Both are more than 99% effective at preventing pregnancy, and the hormonal IUDs have additional benefits of decreasing the pain and bleeding of menses. Many IUD users undergo regular screening for cervical cancer, which is the fourth most common female malignancy worldwide. Chronic infection with oncogenic strains of the human papillomavirus, or HPV, can lead to cervical cancer. Risk factors of cervical cancer are associated with infection of HPV, impaired HPV clearance, and smoking. Protective factors include regular cervical cancer screening and vaccination against HPV. A recent systematic review of case control studies concluded that IUD use decreased the risk of cervical cancer by about a third. However, the individual studies harmonized for analysis did not differentiate device type and were completed before hormonal IUDs were available for clinical use. For example, in the US studies, the data collection period ended at least 10 years prior to FDA approval for the hormonal IUD. And so we were interested in an estimation study that would determine the differential risk of high-grade cervical dysplasia or cancer by IUD device type. So here I show our phenotypes. The target phenotype was the copper IUD, and the index of M was the CBT code for first IUD placement, and there was no subsequent synthetic hormone exposure in that cohort. By contrast, in the hormonal IUD phenotype, which was the comparator cohort, there was at least one subsequent synthetic hormone exposure. Our high-grade cervical dysplasia or cancer phenotype consisted of condition codes for the outcome. All study patients had at least 1 year of prior observation, no history of endometrial or cervical cancer, and were 45 years or younger. The phenotypes were validated with chart review, and our study period was from January 1st, 2003 to December 15th, 2018. Our study window was from 30 days post-placement onwards, and our subgroup analysis was from 1 year post-placement onwards. So we used the Columbia University EHR for our analysis, and we did propensity score stratification and matching for the main analysis. And for the subgroup analysis, we did propensity score matching. The distributions of the copper and hormonal IUDs are shown in red and purple, respectively. And there was about 76% overlap between those cohorts. We see on the right the covariate balance, which was 0.12, but many covariates had a standardized difference, which was lower than that. And about 5% of our negative controls had a p-value less than 0.05. So overall, our study passed the diagnostics. Here we've tabulated the results of our analyses in this study, and we can see that the relative risk of high-grade cervical dysplasia or cancer ranged from 0.38 to 0.64. Additionally, those results were concordant with data from the pre-market randomized control trial for the hormonal IUD that had an estimated relative risk of 0.76. Subsequently, we modified our phenotypes for optimal performance on claims databases. And in those analyses, we found that our relative risks were also below 1 and overall concordant with what came before. So here I've shown a Kaplan-Meier curve of cervical neoplasm-free survival for copper and hormonal IUDs from the matched analysis. And we can see that the curve starts to diverge at about 6 months to a year. In our original analysis, we found that about 1% of our study population was vaccinated against HPV. And since then, we've created a custom variable that draws vaccination counts for HPV both from RX norm and CVX. And with doing that, that has increased this proportion of HPV vaccinated patients in our study population from 1% to about 20%. So we've incorporated that custom variable into our estimation analysis and run it on our latest ETL. The study continues to pass diagnostics, now has a covariate balance of 0.09, and the effect sizes in the latest run were greater than what came before. So in terms of what we're doing next, we intend to replicate our original study on an international cohort of patients from EHR and claims databases. We are seeking EHR partners, and we intend to apply for CPRD and J&J data access. And with that, I'd like to thank all the people who helped me. There were so many, but Dr. Westoff, Kartik and Patrick, Dr. Holcomb, Columbia DBMI, Janssen, IQVIA, and the OHDSI Vaccine Working Group and general community. And with that, I'll take questions. Thank you.
Hey, thank you so much, Matt. Again, we'll do the same thing. Open it up to any questions. There's one from Aiden Colhane. With the hormonal IUD, there were different expiry dates. Did you check this?
Yeah, I'm not sure what exactly is meant by expiry dates, but maybe if that's what I will say about the hormonal IUDs is that we characterized in that the dose of hormone that was administered in the different kinds of hormonal IUDs, and more than 95% of our study population used either the Mirena or specifically or another 52 milligram hormonal device. So in that sense, I think that the whatever expiration dates would probably be pretty homogeneous in our study population because most of them use the original generation of hormonal IUDs. I think a question from Cynthia about the information in the patient record from HPV immunization. So that's a great question. I think there are a couple of nuances to kind of dissect there. So one, of course, is if you're talking about the source EHR versus data that was in the structured OMOP format. And so I think there's different amounts of information there, but certainly in the source EHR, there can be information about HPV immunization, keeping in mind, of course, that EHRs, in particular New York EHRs, can be open cohorts. So there can be variable amounts of information there. The other thing to keep in mind is that the amount of time that patients had, that the window for HPV vaccination was more available to some patients than others, depending on the year of when they had the IUD, because of the fact that Gardasil became more readily available in the more recent years of the study period.